we had an initial introduction to approach to a patient with musculoskeletal complaints. The term arthritis encompasses a large spectrum of disease, which can be divided into acute arthritis and chronic arthritis, depending upon the duration. If the duration is less than 6 weeks, usually we call it as an acute one. More than 6 weeks, we call it as a chronic one. And whenever you use the term arthritis, you should be definite that it is articular. Rule out non-articular problems like bursitis, tendinitis, enthesitis, etc. And our aim should be to have a proper diagnosis and timely therapy and avoidance of unnecessary laboratory testing. Rheumatological diagnosis is mainly clinical diagnosis. Around 70% of the cases the diagnosis is clinical, and around 10% by physical examination alone or added to it, and laboratory contributes to around 5%. Unnecessary laboratory testing often leads to confusion. So the basic approach you should have is determine first, is it articular or non-articular? That is, you should have an anatomical diagnosis. Second, you go by the pathological process. Is it inflammatory or non-inflammatory? Third, the temporal pattern. Is it acute or chronic? Fourth, you think about the joint involvement in number. That is it a monoarthritis, oligoarthritis or polyarthritis? And the pattern and symmetry. And fifth, you identify the other signs and symptoms related to the disease or separate, that is systemic manifestations and extra-articular manifestations. These are the steps by which you go to the diagnosis. Regarding the number of joints, we have already discussed that the one single joint is monoarticular, 5 or more you call it as polyarticular, and 2 to 4 you say it as oligoarticular. And regarding the pattern, we have said in addition you have to think about whether it is a symmetrical involvement, asymmetrical involvement. Is it a migratory one or additive one? Migratory means one joint is affected, by the time the symptoms are subsiding, next joint is affected. This is typical of rheumatic fever. Additive, that can occur in rheumatoid arthritis. And extra-articular symptoms we have already mentioned is very important. So now we go to a case. A 65-year-old female came to the casualty with complaints of right knee pain, which was insidious in onset, started 1 year back. She has no other complaints. She is having mild worsening or stiffness in the morning, but after 5 or 10 minutes, the symptoms subsides. The symptoms are worse towards the evening, especially after physical activity. And over the last 1 year, she is having this symptom, and now she has pain over the left knee also. On examination, patient had no clinical evidence of effusion. Palpable bony ridges along the medial and lateral edges of the knee joint present. Tenderness was elicited along the medial and lateral part of the joint lines. And on movement there was crepitus. That is, there was limitation of the movement. The patient was uncomfortable with the motion of the affected knee throughout the range of movement. There was no instability. Other examination and other joints were normal. Here, physical and systemic examination, other systems were all within normal limits. Now how will you approach this patient? First question, as already mentioned, is it articular or non-articular? Definitely it is articular, because when there is swelling is there, bony deformity is there is tenderness around the joint line. A patient with a non-articular problems, usually the pain is limited to a separate the particular point only. That is when the tendinitis at that site of the insertion of the tendon. Whereas in a arthritis, you get a diffuse pain and there will be tenderness along the joint line. So it is a first question, it is articular problem. Second question, is it inflammatory or not? There is some evidence of inflammation is there. So, but considering the amount of swelling, the signs of inflammation are lacking. So the typical signs of inflammation are pain, warmth, redness, swelling. So we can say that this patient is not having an inflammatory type of arthritis. And the characteristic feature of inflammatory arthritis is morning stiffness, prolonged morning stiffness. Here patient has some morning stiffness, but it disappears by 10 minutes. In inflammatory joint diseases or inflammatory arthritis or autoimmune arthritis, what we get is a prolonged 30 to 60 minutes or even more than 60 minutes. This gel phenomena is classical of inflammatory arthritis, which is missing here. So we can say this is a non-inflammatory arthritis, and the most common type of non-inflammatory arthritis is osteoarthritis. The number of joints involved here, it is more than one. So this, and it is a, can call it as a oligoarthritis. It is non-inflammatory and typically clinical history wise it is osteoarthritis. Now we look at whether any systemic features are there. Whenever there is a monoarthritis or predominant monoarthritis, always rule out septic arthritis, crystal induced arthritis and traumatic arthritis. So these are the three important points. In septic arthritis, usually there will be some predisposing factors, fever and other things will be, and significant signs of inflammation will be there. In crystal-induced arthritis also there is inflammation will be there, significant inflammation, especially gouty arthritis. Patients will have severe pain. They will not, excruciating pain, they will not allow you to touch. So it is not a crystal-induced arthritis. Next, is it acute or chronic? Here it is a chronic one over the last 1 year. So it is a chronic problem. And we have already discussed the symmetry or the pattern. Here is asymmetrical. So additionally, you should ask about whether the spine is affected, whether it is a larger joint is affected or a small joints are affected. So in summary, we can say that this patient has got a chronic oligoarthritis, asymmetrical, without signs of much inflammation, no involvement of the spine, and this is typical osteoarthritis. And what are the investigations? Usually the routine blood examination will be normal because the ESR, CRP, etc. elevate only inflammatory arthritis. The only investigation you need is an X-ray to see whether there is any radiological features of osteoarthritis, which we will discuss later.